Hello, happy Friday, everybody. Dr. Aimee Ostick here with Health and Healing Direct Primary Care.
And Dr. Brian Ostick. And before we get started, I want to say thank you to everybody out there who liked, shared, commented on the video that we did 2 weeks ago.
Mm-hmm.
We absolutely destroyed my mom's video in terms of metrics. Part of that may have
Maybe not content, but that's okay.
Yeah, part of that may have had to do with I used part of the advertising budget to boost that video, but all's fair.
Cheater.
All's fair in love and war.
That's all good. That's all good. You will be very useful today, though, my friend, my husband, because we're going to talk about hydroxychloroquine and zinc and kind of the controversy going around right now this week. And on a larger scale, though, I would like to frame the conversation and the discussion just around research and why, as physicians, how we make decisions and judgments based on what we do clinically and how we make those decisions. It's not random. It's not based on feeling or opinion.
Right. There really is a scientific method.
There is a scientific method behind it all, believe it or not. And as physicians in medical school, what you learn how to do in medical school through your undergraduate studies and then also through residency is how to discern and read literature, how to understand studies and what makes a good study and what makes a study better than another study and what the inferiority and superiority of those studies look like and why.
Yeah, we had journal clubs every month in residency for 3 years. So 36 different journal clubs where the whole point was to read an article or more, come back with a group of doctors, attendings, and residents, and then discuss the article and say, was this a good article? Was it bad? How did they do it? What were the methods they used? What was the power of the study? How many patients were involved? Did it prove what they were setting out to prove?
Right, exactly. And, in this month's blog for Health and Healing Direct Primary Care that is actually on my website now, there's a really nice little graph, and I talk about sort of the hierarchy of evidence in medical literature. And at the very top, we have kind of, meta-analyses, and then you have randomized controlled trials, all the way down to opinion-based papers, case studies. So it's basically like me saying, I put somebody on this medication and they got better is not as good as somebody doing a randomized study that's blinded or double blinded, meaning the patient nor the provider doesn't know what they got. They got placebo or a medication, and then you watch the result happen.
What's placebo? Explain what that means.
Placebo will be like a sugar pill. So if somebody gets hydroxychloroquine, you say, here's 350 patients, here's 400. Some of these studies of hydroxychloroquine that came out in June, July, that were published in NEJM were 600, 700 patients.
NEJM is the New England Journal of Medicine.
Correct. Yeah. So they gave patients, and there's several studies. Again, on my blog, I post the links to those. There's several studies looking at putting people on hydroxychloroquine and zinc, or hydroxychloroquine and azithromycin and zinc, or hydroxychloroquine alone. Various protocols, either in prophylaxis, so meaning treating someone like this guy here who's a high risk, healthcare worker, let's say, or mild cases, people that outpatient, they don't have very mild symptoms, you put them on hydroxychloroquine, severe cases, so patients in the hospital, and then post-exposure prophylaxis too, so meaning somebody gets exposed, you put them on hydroxychloroquine and then you watch. So all different studies looking at these various treatment protocols, randomized, double-blinded, controlled.
So randomized means we take two groups of people. One of the groups is going to be controlled. That's their control. They're just going to get the placebo pill, the sugar pill. And then the other group is going to get the test medication, whatever that is, maybe hydroxychloroquine in this study.
Right. Randomized means there's no selection bias, right? So you randomly select people. You're not going to select the healthier person over here versus the not, right? You randomly select people. Controlled means maybe you control for other various factors. So maybe they have a similar disease state. Maybe they are age matched, right? They're the same age, same comorbid conditions. Maybe there's also ethnicity controls as well. So they try to control for all other variables, things that would otherwise muddy the water in terms of interpreting the data. And then blinded or double blinded would mean that neither the patient nor the person administering the medication knows what they're getting. So there's hopefully there's no bias that way. So you remove all the bias, you remove all the variables as much as you possibly can. You give somebody these medications or the placebo and you watch the outcomes. So all these studies were conducted, and really it did not show, the treatment group really did not show significant improvement in either survivability, meaning surviving the severe disease, or worsening of their disease, or in the cases of post-exposure prophylaxis, meaning giving it to somebody after they were exposed, in lessening their likelihood of getting the disease. So, we've sort of, in the beginning of this, I was like...
Well, right now
in March, go ahead.
At our hospital, we initially were treating patients with hydroxychloroquine because the data was initially saying that there might be a benefit. And then when these other studies came out saying, well, that may not be true, there may not be a benefit, and there may be an element of harm with the electrical activity of the heart with hydroxychloroquine is really the concern, that maybe it could be dangerous in certain situations. And so we have backed off, and we're not treating patients with hydroxychloroquine empirically, meaning every patient with COVID gets it. We are moving into treating patients with remdesivir, which has seemed to show some benefit. And so we have a specific patient population that we will use that for. And then the other thing is steroids in the patients that are really sick. But as this scientific data comes out, we change our management.
Of course, and that's what we have to be willing to do here, is to be flexible and nimble and humble in this disease, because we're learning as we're going. We also have to make sound clinical judgments based on the best possible data there is.
Right.
Just because a doctor comes out and says, I anecdotally treated 300 patients that I neither randomly selected, nor did I control any factors for, nor did I blind their treatment protocols. I just saw that they got better. Who knows? Maybe they all just got better because they just got better and they never were really that sick to begin with.
Right.
So the worst thing that would happen would be that we give somebody something that potentially could cause harm and did not cause any benefit. It didn't shorten their course of disease, didn't improve their morbidity or mortality from that disease. And that's why I've backed off on hydroxychloroquine. And I was, in the beginning, kind of gung-ho too, looking at all the in vitro studies, which means studies done on animals, studies done in the lab, looking that actually chemically, biochemically, it made sense, hydroxychloroquine, right? But then when you actually applied it in the clinical world, it didn't.
What's interesting is that in medicine, a lot of things that we do is risk versus benefit. There are certain risks that we take when giving anybody a medication. Side effects can be mild to severe. But then we look at the benefit. If we're giving this medicine, what is the potential benefit to the patient? And when you talk about statistics, there's two things that we look at, which is number needed to treat, but then on the flip side, there's the number needed to harm. So, for example, you're giving aspirin to prevent heart attack and so forth. The number needed to treat may be 1 in 8 patients. So out of every 8 patients that you give aspirin to, 1 person will benefit, which is really good.
Yeah.
And on the flip side, there's a number needed to harm. So out of every 1,000,000 patients that you give aspirin, 5 of them may bleed from it. And so that's a harm that you're giving. But the risk is less than the benefit that you're giving them. So that's something that you have to take into account. It's not like, this drug is completely safe in every situation. Every medicine or drug that we give has potential risks.
Exactly. And I think that's the point here, is that if all these people, especially the mild patients, if they get better on their own and we don't have to give them something that potentially could cause harm, that's the right thing to do. So unfortunately, it's been turned into a political volleyball, and that's the unfortunate piece of this. Is both ways it's been used as kind of fodder to push a political agenda. So in my blog that is on the website now, I try to encourage everybody not to kind of make medical judgments on headlines, So you see a headline, check your sources, know what you're reading here, what is everybody's agenda, and make sound medical opinions based on the quality of data that's coming your way.
Right.
Okay?
Not all scientific research
is
good
created.
scientific
No,
research.
exactly. So,
The New England Journal of Medicine that we mentioned earlier
Yes.
is considered one of the stronger, better medical journals out there. And so the articles that get into there, I think it'd probably be amongst the medical profession given more credence than other journals. There is a lot of scientific journals out there. Some of them even called throwaway journals because they're, you get them and you're like, I don't know what to believe in here.
Yeah.
But something like the New England Journal is something that you can usually say, gosh, this has been really reviewed. The studies in here have been good, high quality studies. We're going to take what they say and probably try to incorporate it into our practice if we can.
Exactly. And this whole process has taught me a lot of humility too, and I'm sure you as well. But anyway, we're here for you.
Yeah.
I thought I'd get that out there. I've had a lot of people text me that video, and it's wild to say the least. So call us if you need anything, 818-600-2426. Health and Healing Direct Primary Care. I'm Dr. Aimee Ostick.
And Dr. Brian Ostick, thank you.
Thank you. Good discussion.
Good discussion.